بسم الله والصلاة والسلام على سيدنا محمد وآله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. The first lecture in this course will be about the evidence-based strategy for prevention of postpartum hemorrhage. As we know that prevention is the first thing to be done before the complication occur. TACO is transfusion-associated circulatory overload. This is a transfusion reaction caused by rapid or excessive infusion of blood product leading to acute pulmonary edema. It occurs when the fluid from the transfused blood product exceeds the circulatory capacity of the recipient, causing increased hydrostatic pressure in the pulmonary vasculatures and fluid leakage into the lung. And this is what we call pulmonary. As you know, I love pathophysiology. Rapid or excessive volume of a blood product increase the intravascular volume and hydrostatic pressure, and this is lead to the fluid shifted into the alveoli and acute pulmonary edema. How to predict TACO? Think TACO before, during, and after transfusion in every patient. The more risk factor presents, the higher the chance to develop the TACO. The TACO is a transfusion-associated circulatory overload. So we are inducing TACO if we induce or if we transfuse large amount of volume of a product like bacterial blood cell, fresh frozen plasma, cryoprecipitate, and so on. Rapid rate of transfusion more than 5 ml per kg per hour. Fast infusion exceeding the body ability to adapt it and clear the excess volume and solution. Multiple components given increase the immunological and metabolic and inflammatory burden. Massive transfusion without monitoring urine output or hemodynamical monitoring. We explained it in the previous lecture, monitoring of the patient during blood transfusion. If you fail to monitor your patient, you might end up by overloading the circulation. Careful planning, appropriate rate, component selections, and close monitoring are essential to minimize the risk. Always follow the institutional massive transfusion protocol. Patient-related risk factor for transfusion-associated circulatory overload, TACO. Patients with heart failure, reduced ejection fraction or diastolical dysfunction, chronic kidney disease with renal impairment, pre-existing fluid overload, particularly patients with preeclampsia, positive fluid balance, input exceeding the output, severe anemia where requiring large transfusion volume and risk of TACO, body weight, if the less body weight reserve high risk of the volume overload, hypoalbuminemia as it's occurred with preeclampsia, pregnancy and postpartum women receiving aggressive fluid resuscitation before you start the blood transfusion, and this is a result in the physiological change and large fluid volume and high risk of TACO, critically ill patients in the ICU, hyperdynamical instability, capillary leakage, organ dysfunction, and high risk of TACO. Again, درهم وقاية خير من قنطار علاج. The prevention of TACO in high-risk patients. The goal is to transfuse safely and giving the right blood to the right rate to the right patients. To be able to prevent the TACO, we have to consider the transfusion only when clearly indicated, avoiding unnecessarily transfusion, and use restricted transfusion policy. Use weight-based transfusion, 1 unit packed red blood cell equal to 7 to 10 ml per kg. Reassess after each unit. Transfuse 1 unit at a time at a high-risk patients. Infusion slowly, then reassess the clinical picture of the patients and consider testing dose approach. Slow the transfusion rate to less than 3 to 4 ml per kg per hour, which is equal to 2 to 3 hours for each unit. Avoid rapid infusion and large volume, which is sometimes very difficult to be done in a patient with a massive blood transfusion. Monitor closely. This part you have to concentrate. And if you are not absorbing exactly how you will monitor your patient, go back to the lecture before of monitoring the patient. Consider a prophylactic diuretic, 20 to 40 milligram, may be considered in a high-risk patient, and use cautiously and monitor the blood pressure and renal functions. Use point-of-care testing to guide therapy. Use the ROTAM and TIG or the lab to target the product and avoid over-transfusion. Maintaining accurate fluid balance, record all the input-output, monitor urine output more than 0.5 ml per kg per hour. Educate and follow the policy for massive transfusion protocol. Patients with high risk like heart failure, chronic kidney disease, pre-existing fluid overload, severe anemia, pregnancy, postpartum, critical illness, ICU patient, elderly, low body weight, all of them should be giving the blood cautiously. Continuous monitoring for all the monitoring information. I wouldn't repeat it. You can go and you have to know how to monitor your patient during the blood transfusion. The key point, prevention is the best treatment, careful assessment, slow transfusion, and the close monitoring will lead to safe patient and better outcome. Sign and symptom of transfusion-associated circulatory overload, TACO, in postpartum hemorrhage, typically developed during transfusion or within 6 hours after the completion. There is respiratory symptom and there is cardiovascular. For respiratory, acute dyspnea, shortness of breath, there will be orthopnea, worsening with the patient lying down, tachypnea, respiratory rate more than 20, hypoxemia, the oxygen saturation will be less than 90, and pulmonary edema, bilateral crackers and the fluids in the lung, pink frothy sputum, severe cases. Vascular, like hypertension, the patient may be systolic more than 140, tachycardia, heart rate more than 100, elevated jugular venous pressure, and S3 gallop may be present, and peripheral edema can be there. So generally, anxiety and restlessness, cyanosis, reduced exercise tolerance can develop. And remember, positive balance, fluid balance, less than reducing the urine output. So the key point that the TACO resulted from the fluid overload due to rapid or excessive transfusion leading to pulmonary edema and circulatory overload. The postpartum women with PPH are a high risk due to large fluid shifting and massive transfusion. Early recognition is essential. Prevention of TACO is critical for every obstetrician. We divided the prevention strategy into before transfusion, during transfusion, and after transfusion. Well, before transfusion, you have to assess your patient. Good, careful history of cardiac, renal, hypertensive disorder should be taken. Calculating fluid balance, IV fluid and blood product, and use conservative transfusion threshold when it's possible. In high-risk patients they're having heart rate, valvular disease, renal impairment, preeclampsia, gestational hypertension, advanced maternal age, and multiple transfusion and large IV fluid intake. During transfusion, slow the transfusion rate to less than 2 ml per kg per hour when the patient is not in postpartum hemorrhage. Because the patient, if she is in active severe postpartum hemorrhage, blood is a saving measure. But remember that even if you are giving the patient massive blood transfusion protocol, you have to monitor your patient with pulse oximetry, respiratory rate, blood pressure, pulse pressure, and urine output, and all the measures which we are mentioning about in the lecture of monitoring. Using diuretic is essential in some cases between the unit of blood transfusion, especially in massive transfusion protocol if the patient is not hypotensive. After the transfusion, reassess the respiratory status, auscultation, saturation, and the fluid balance. And check the post-transfusion lab and adjust the fluid accordingly. And also adjust the plan of blood transfusion. If your patient is planned for multiple transfusion, you have to check it if the patient is stable and adjust your plan. Maintain appropriate fluid balance to prevent overdose or overload. Prevent the TACO, assess the risk, transfuse carefully, monitor closely, and reassess and adjust. Know your patient, transfuse wisely, monitor continuously, and protect the mother and protect the baby. TACO is preventable. Thoughtful assessment and careful transfusion and vigilant monitoring save life. Diagnosis of TACO. Think TACO in any patients who developed respiratory distress or sign of fluid overload during or within 6 hours of transfusion. How to diagnose TACO? TACO diagnose if it's met more or equal to 3 criteria according to SPIT and CDC criteria. TACO is likely if more than or equal to 3 of the following developed within 6 hours of transfusion. What is this criteria? Acute respiratory distress, dyspnea, tachypnea, orthopnea, hypoxemia, crackles on auscultation. Elevated the PMP or evidence of cardiac overload. More than PMP more than 300 picogram per ml. Suggested ventricular strain and volume overload. Radiological evidence of pulmonary edema, chest X-ray show bilateral alveolar or interstitial edema, vascular congestion, and Kerley-P line and pleural effusion. Positive fluid balance, cumulative fluid overload, IV fluid plus blood product exceeding the output. Hypertension, a new onset hypertension or worsening of the hypertension which is already exists within 6 hours of the transfusion. Cardiovascular changes like tachycardia, a new S3 gallop, or a raised GVP, peripheral edema. So, if it's occurred 3 or more of any of these factors, most probably the diagnosis is TACO. Revising, summarizing, onset within 6 hours, may feature volume overload, loading pulmonary edema, hemodynamically hypertension, risk factor, cardiac disease, renal disease, elderly, multiple pregnancy, fluid overload, massive blood transfusion. PMP elevated, usually more than 300 picogram per ml or raised. Response improving with the diuretic and supportive care. Remember, we already explained the difference between TACO and TRALI. I wouldn't cover it now again. So the clinical message, early recognition of more than 3 criteria within 6 hours of the transfusion, allowing proper diagnosis and treatment, preventing worsening of respiratory failure and morbidity. Think TACO, assess a crisis, balance the fluid, treat promptly, prevent complication. Early identification, apply more than 3 criteria, differentiate from the TRALI, treat early, and improve the outcome. How to manage TACO? TACO is medical emergency. Early recognition and early management can save life. So the first thing, you have to take a quick history, review the patient's file, see the input-output chart, see the vital sign and the monitoring which you are doing, how much fluids, how much unit you give, what is the urine output, to be able to differentiate between TACO and TRALI. Stop the transfusion immediately, but don't get rid of the unit. Maybe you can use it again. Provide oxygen support and give high flow oxygen, 10 to 15 liter, targeting the oxygen to be more than 94%. Consider non-invasive ventilation, the CPAP or the PPAP, if the respiratory distress persists. You have to also elevate the head of the patient 45 degrees, encouraging the upright position, and consider CPAP and PPAP. Give furosemide, diuretics, and repeated the dose as needed based on the response and the hemodynamical stability of the patients. Monitor the urine input and output. It should be more than 0.5 ml per kg per hour. The action should be monitor the blood pressure, heart rate closely, and hypertension, treat if it is there, hypotensive, treat if it's there, like vasopressin, norepinephrine, and avoid excessive fluids. You should investigate the patient with chest X-ray and ABG, hypoxemia, and the PMP will be elevated. The hemoglobin and renal function test electrolytes should be monitored, and monitor input, output, and daily fluid balance. Continue treatment until the TACO is resolved. The improvement, breathing and reduction in the distress, the oxygenation should be more than 95. It's good sign, and a stable vital sign, and the blood pressure. Increase the urine output more than 0.5 ml per kg body weight, and improving the chest X-ray finding, and improving overall clinical status. Remember that early recognition, immediate action is better outcome. The key message: stop, support, diuretic monitoring, and timely management of the TACO save life and protect the mother. How to reduce the future risk of TACO? The key strategy for the safe transfusion obstetric practice: preventing volume overload and protect maternal safety. Through use the weight-based transfusion volume, calculating the transfusion based on the patient weight, clinical status, ongoing blood loss, and hemodynamical response. Individualize the dosing, reduce the risk of the fluid overload. 2. Avoid unnecessary transfusion once the bleeding control. Reassess your patient. Monitor your patient carefully. Stop the transfusion when stable and prevent unnecessarily volume overload. Right patient, right product, right time. 3. Use point of care test, ROTAM, TIG, to target the products rather than over-transfusion. Identify the specific coagulopathy. Give the target product, fibrinogen, platelet, plasma. Avoid empirical transfusion and reduce exposure and volume load. Target therapy, better outcome, and less risk. 4. Document the TACO events in medical record of the patient and transfusion service logo, and ensure the accurate documentation, inform transfusion service, and flag the patients. Support the quality improvement and the patient safety. If there is no policy, create policy. Enter this case into maternal mortality and morbidity, so everybody will learn from the lesson. Document the preventing recurrency and improving the care. So the key message is right volume, right patient, right product, right monitoring, safer transfusion, and low risk of TACO. Careful transfusion practice today, protect the mother tomorrow. Thank you for your commitment to excellency in women healthcare. Together we are shaping safe care, improving outcome, and supporting every woman at every step.